Okay, great. Just imagine, though, I really appreciated that last talk. Imagine if we had let middle income and lower middle income countries charge indirects. The world would be a very different place. No institution in the United States would take on research without the ability to have indirects. And so I think these are the kinds of things where when there's a system change, we have to really look at this in a more credible way. So intentionally focusing on sustainability through controlling the epidemic, and so that sustainability itself must be a focus of every program decision. And I want to try to take you through some of that and some of this discussion about how it has to be very intentional. I heard someone talk about country-owned and country-led. Let me make it very clear. The country needs to own the epidemics that they have, not the epidemics they want to have. Because it's impossible for countries to lead when they don't recognize the epidemic they have. And this gets into the whole issue of political will. And what's often not discussed when we talk about country-owned and country-led is the engagement of the community and the critical role of the community's voice and the community health system in the whole situation. So a couple main message. We took a slightly different approach rather than countries' capacity or a country's financials ability. We looked at the burden of disease and solely at the burden of disease and said, what would it really take in co-financing to change the course of these pandemics, and saying that you don't talk about transition until you're at a place where you've reached a steady state. So at no time should we be handing over an epidemic that's expanding. But collectively, as a global community, we should only be handing over epidemics and believe that they could be transitioned when they're actually controlled on some level. Whether it's, imagine if we walked away from Ebola while the cases were still rising. And sometimes that's what we talk about and do with countries, just based on their ability or perceived ability to pay. We know that controlling the HIV pandemic that I'm going to talk about, but any pandemic, is key to a country's long-term fiscal capacity. And so unless we get countries collectively over these hurdles, and when we talk about disease, particularly HIV today, we're talking about a time when incident rates are declining, but burden of diseases are not because of the youth bulge. Because we have a disease and we have an epidemic that is most evident and most relevant to 15 to 35-year-olds. And now we have twice as many in Sub-Saharan Africa as we did at the beginning of the epidemic. So it's no longer just relevant to talk about incidence rates, which are going way down, often by 50, 60% just in the last 5 years, but to really talk about what that means for burden of disease. And then prioritizing program performance. I loved it when they talked about in the last session. I had to go to the overflow room because there's big screens there and you can see them. So I loved it when they were talking about trillions of dollars. We need to harvest the billions we have now and ensure that every dollar is being utilized cost effectively. And so we've really worked around these principles of accountability and transparency to deliver impact. But in order to do that, you really do have to be transparent. So if you go to pepfar.gov, all our results are up there down to the site level, where you're serving the client. That's where you have to be able to see things, not in an average at the county level, not in an average at the national level, but disease and risk of disease and complications of disease exist in the communities at the individual sites, so you need to be able to see them. Now, I show this slide between the Global Fund and PEPFAR. We have intentionally worked together in a really much more transparent and accountable way. And so over the last 4 years, both of us were able to double our results in a flat budget. So this is what's possible when there's an intentionality at the government level and political will and at the multilateral and bilateral level. And so we've really spearheaded this, bringing all the budgets together and looking how every single dollar is being spent, no matter where it came from. It came from the host government, came from another bilateral, came from another multilateral, or it came from PEPFAR, to really ensure that every dollar is invested. We found a lot of duplication. No one is going to stand up and say, oh, I was already paid to do that. I haven't seen that yet, so let's just be clear about that. So we have to find it, and we have to ensure that that is, but most important are the core policies, and this is where political will is so extraordinarily important. Because if the government won't adopt and develop the policies that are needed for the execution of the program to be successful and have the impact that it needs to have, then you fail. So you can put lots of resources into something, and I will call attention to the difference between West and West Central Africa and Eastern and Southern Africa in the coverage of services. It is primarily due to one reason: informal and formal fees. So if you don't change that policy, we can keep doubling and tripling the money in West and West Central Africa, and we still won't have any coverage of services. So unless we stand back and say, okay, we need this policy change or none of us are going to be successful, I know it may not be popular, but what it is doing, it is keeping the poorest women from ANC care. We know that there's example after example. So these are the kinds of things as a global community we have to address in order to be successful. I show you this slide because this is what's possible. If you had said 15 years ago, 85% of the individuals in East Swahili or Swaziland knew their HIV status. If you were over 14, no one would believe that is possible. But it's possible in Swaziland, it's possible in Lesotho, it's possible in Zimbabwe, it's possible in Malawi that has probably the least healthcare workers in many areas. It wasn't dependent on what you had. It was dependent on the governments developing systems that adapted and utilized what they did have for success. And that's really quite remarkable. The countries that had the least, in these first community level surveys, the least evidence-based of performance were the highest funded countries by Global Fund and PEPFAR, and that was Uganda and Tanzania. So it is not a resource issue. It is a political will, it is a focus, it is a community engagement issue. This is what's possible. This is the bottom line. The dark blue line shows how deeply we've decreased prevalence in young people just in the last 5 years in Swaziland and in Namibia, when they found a huge epidemic across the north with very different languages, tribes, and access. They were able to get up to 68% viral load suppression at the community level. 68%. That means almost nearly 70% of the individuals in that community are on their medication, taking their medication, and virally suppressed so that they're healthy themselves and they're not transmitting the virus. So where are we in progress? I'm just going to show you just two countries, two different stories. Malawi, and you can see both the number of new infections by an absolute number and the number of deaths by an absolute number continue to dramatically decline despite a youth bulge and an increasing population. This is UNAIDS data. And this is South Africa. So there was a time, 4 years ago, people were talking about transitioning the program out of South Africa. South Africa is investing billions in their epidemic, but they needed additional resources to get themselves over the core barriers, and we're working with them to do that. So this is not just being a middle-income country. This is looking at the burden of disease. They have 7 million people HIV infected. And they have regions of their country where 35% of the women are positive by the time they're 30. So together, we need to ensure that South Africa looks like Malawi, and then we can talk about futures of transition. What does this look like across 7 countries? The importance of data and granular data, not only at the facility level, but in surveys that shows really what you're doing every day in your program. This just shows us that we haven't reached men. And so it doesn't matter if you're 14 or 30, you haven't been diagnosed. Why is that? Because we built a healthcare delivery system for Sub-Saharan Africa based on pregnant women and children under 5. So if you're 25, you don't see a reason to go there. And for years, you've been told you don't need to go there. So when we talk about what needs to be done in the future, finding 21st century solutions, not continuing more of what we've been doing. That's not going to get us to the place. I'm showing you that half the men don't know their diagnosis because they don't interact with the healthcare delivery system. So we have to create the healthcare delivery system for the 21st century. We can't do the same thing and pretend that men are going to show up. We can't do the same thing and pretend that 18-year-old women are going to show up. And so we continue to evolve the program based on the individual needs of the community and government in those regions. Every place is different, every need is different, and adapting the program based on data. I want to show you quickly the Rwanda data because this is why the site-level data is so important. This is the viral load suppression of every single site and clinic in Rwanda, down to the health center level. And you can see across the board they have very good results, and then they have this small wedge of individual clinics that aren't doing as well. So if you did everything equal to these clinics, you wouldn't be fixing the 20% that had the issue. And that's our other problem. We go to all of them and pretend they're all the same. They're not. Only 20% needed the additional investment, the additional human resources to respond to this issue. Now, if you're children, if you're under 15, it's half the clinics. And if you're 15 to 24, it's half the clinics. So that says that what we're doing for older adults is working, what we're doing for younger adults in the exact same clinics, in the exact same region, not working. So it's this kinds of data, when you have it down to the site level, that really gets you to be able to define exactly what is needed by the population. Now, I'm talking about HIV, but it wouldn't matter if you were talking about education. It wouldn't matter if you were talking about gender-based violence. These issues occur in pockets, and it's our job to work with countries and communities and governments to have the information that ensures that people and individuals are seen through our systems, and we can respond in a very specific way that allows resources to be targeted in a way for maximum results. Thank you.